Hello and welcome to today's webinar on nutritional interventions for allergy prevention. What is the status in 2021? My name is Hania Szajewska. I'm professor and chair of the Department of Pediatrics at the Medical University of Warsaw. My scientific heart belongs to a number of organizations, including ESPGHAN, European Society for Pediatric Gastroenterology, Hepatology and Nutrition, ISAP, International Scientific Association for Probiotics and Prebiotics, and last but not least, to EACI, European Academy of Allergy and Clinical Immunology. Let me start my presentation with this BMJ cover. One can call it politically incorrect cover because you can see an infant who is formula fed. However, this cover calls our attention to an extremely common problem in infants and young children, and this is cow's milk allergy in children. Every now and then people are asking this important question: is the number of food allergies increasing or decreasing? And as a matter of fact, many people believe that the percentage of people with food allergy is increasing. However, with few exceptions, there are no data that can clarify whether this is in fact true. And what are the problems with assessing the prevalence of food allergies? Well, there are many. I summarize some of them on this slide. There is a lack of high-quality evidence based on the gold standard of oral food challenges to determine food allergy prevalence. And different studies use different study designs. Studies differ with respect to populations included in the study and diagnostic procedures used to identify food allergies. And last but not least, there are also geographic variation. There is lack of high quality evidence, but there are some exceptions. And one of the exceptions is this Europreval birth cohort study, which was carried out in 9 European centers to evaluate what is the prevalence of some of the food allergies, including cow's milk allergy. And I'm showing this slide to you and the results of this Europreval birth study because it shows nicely that there are geographical differences. The highest risk of cow's milk allergy was shown and documented in countries like UK and the Netherlands, and the lowest risk below 0.3% in Lithuania, Germany, or Greece. So there are national incidences ranging, there are national or geographic variations. Overall, the incidence of challenge-proven cow's milk allergy was 0.54%. There is no ideal study. There were some comments with regard to these Europreval studies that gastrointestinal non-IgE-mediated cow's milk allergy were not adequately captured and therefore underreported in the Europreval study. And this may be because the diagnosis of gastrointestinal cow's milk allergy is difficult and there is an overlap with common functional and infective gastrointestinal conditions. Still, this study is important because in all the centers, the diagnosis was made exactly the same way. The same applies to another part of the Europreval study when they looked at the hen's egg allergy. And again, there were some variations when it comes to national incidences, ranging from below 0.07% in Greece to 2.18% in the UK. And again, there are geographic variations, as you can see here, that this shows you adjusted mean incidence, which is 1.23, and there are a geographic variation, as you can see on these results from Australian Health Nut study, and for egg allergy, hence egg allergy, there was a prevalence 9%. So my summary number one for the prevalences of allergies is food allergies are and will remain a source of concern for the children, their parents, and healthcare professionals. However, they might be, and I did try to show it to you, some geographic variations. Well, food allergy is a big problem. Cow's milk allergy is a big problem. Management is not easy, and we all agree that prevention is always better than cure. And people are really interested in early nutritional strategies for preventing allergy. On this slide, I summarize some of these nutritional interventions, and I will discuss each one of them in more detail. In my presentation, very much I will rely on the findings from the systematic review, which was performed by IACI Food Allergy Anaphylaxis Guidelines Group and was published in 2020 in Pediatric Allergy and Immunology. And I will also refer to a very recent document, which was also published by IACI, which are updated guidelines on preventing the development of food allergy in infants and young children. This document refers or addresses IgE-mediated food allergy. On this slide, and this comes from the document which I just showed you, there is an overall summary of effect sizes. Of course, I do not expect you that you will read it in details, but what I would like to call your attention is that, as you can see, for many interventions, there were very limited evidence, 1 or 2 trials. And of course, when we are discussing randomized control trials. But now let me discuss each one of those interventions one by one. Starting with breastfeeding. As a pediatrician, we have recommended breastfeeding. Exclusive breastfeeding for 6 months is a desired goal. But I would like you to reflect for a moment on this statement. Breastfeeding has many benefits for infants, but it may not reduce risk of food allergy. Please reflect whether you strongly agree with this statement, you agree, you are undecided, or you disagree. This presentation does not allow me to see your answer, but it's not so much that I want to see your answer, but I just want you to think about your personal opinion. And now let me comment on it. When you look at breastfeeding and allergy, and you look what is the evidence, that you will see that there are findings, there are studies showing no association, showing a reduced risk, or showing an increased risk. So this issue remains controversial. The question is why there are inconsistent results. And there are many factors contributing to those inconsistent results, including confounding factors, gender, age. For example, asthma. To make a reliable diagnosis of asthma, you need to have a child who is already at least 4 or 5, 6 years old. Socioeconomic status, family history of atopy, parental smoking, or presence of furry animal in the home. Recruitment and reporting biases may contribute to the inconsistent results. Inability to randomize and blind. There is no ethical committee which would agree to randomly assign children to be infants to be breastfed or formula fed, and blinding is also not possible. So this really contributes the results, of course, immediately in the selection bias. Many studies do not make the distinction between exclusive breastfeeding and any breastfeeding. There may be some imprecise definition, for example, asthma, or for atopic dermatitis, or for food allergy. They also may be reverse causality. Infants at the highest risk of allergy might be breastfed for longer periods, and then this longer period of breastfeeding may be considered as responsible for allergic symptoms. So there are many reasons, many factors contributing to those inconsistent results. So the question is, when the results are inconsistent, what to advise? And all scientific organizations, all expert groups agree exclusive or full breastfeeding in all infants for about 6 months is a desired goal. Breastfeeding is important for the other benefits, even if it does not reduce the risk of allergic diseases. And very similar is very recent recommendation from IACI. There is no recommendation for or against using breastfeeding to prevent food allergy in infants and young children, but breastfeeding has many benefits for infants and mothers and should be encouraged whenever possible. But if you look at the rates of exclusive breastfeeding worldwide, you will see it's about 41%. The 2025 target by World Health Assembly is 50%. So we can see that exclusive breastfeeding rates among children under 6 months are well below target. And I am not sure that we will reach to this to 50% in 2025. And even if there will always be a need for human milk substitutes, no matter how successful the promotion of breastfeeding. And this is my summary number 2. Breast is best. However, there was and will always be a need for human milk substitutes. And this brings me to the second statement, which I would like you to reflect on. And this is, if breastfeeding is insufficient or not possible, hydrolyzed cow's milk-based formula should be used for infants at high risk for the first 4 months. And again, please think whether you strongly agree, you are undecided, or you disagree. So you know now your own opinion, and let's have a look what is the evidence. As you know, when it comes to hydrolyzed formula, there are 2 major types. These are partially hydrolyzed formula or extensively hydrolyzed formula. And of course, we do have amino acids formula, which is really the mixture of amino acids. And there are different indications for the use of each one of them. Here on this slide, I showed you that until 2016, all societies recommended formulas with documented reduced allergenicity in high-risk population. High-risk populations, I mean for allergic diseases, and this was usually defined that there is a positive history of allergic diseases, documented positive history in the family. But then the situation has changed, and this was very much caused by this systematic review and meta-analysis which was published in BMJ and by Robert Boyle and his colleagues. And this meta-analysis concluded there is no consistent evidence to support the use of hydrolyzed formula for the prevention of allergic diseases. Allow me to comment on these meta-analyses. Not all hydrolyzed formula provide the same degree of protective benefits. And this is because factors such as the protein source, hydrolysis method, and degree of hydrolysis that often depend on the manufacturer contribute to differences among hydrolysates. And even if partially hydrolyzed and extensively hydrolyzed formulas were evaluated separately within each one of those groups, please remember that within each group, not all hydrolyzed formula are the same. Because, allow me to repeat again, protein source, hydrolysis method, they are very important, may contribute to the differences among hydrolysates. Those, the efficacy and safety should be established for each hydrolyzed formula, from each manufacturer, I would say. And keeping this in mind, together with my colleagues, already some time ago, we published this systematic review that we looked at partially hydrolyzed 100% wheat formula and the risk of allergy. And so we only focus on one very specific type of formula. And we concluded that there is evidence to consider use of partially hydrolyzed formula as an option for reducing the risk of all allergic diseases, particularly eczema, because we showed in our meta-analysis that there was reduction at least at some time point intervals, although not all. Certainty of the evidence was low, and one characteristic that made our meta-analysis distinct from other reviews is that it focused exclusively on only one type of partially hydrolyzed formula. There is another systematic review, which is a Cochrane review, and this Cochrane review concluded there is no evidence to support short-term or prolonged feeding with a hydrolyzed formula compared with cow's milk formula for prevention of allergic diseases. So altogether, when you look at hydrolyzed formula for reducing the risk of allergy, there are at least 3 systematic reviews and meta-analyses published recently with inconsistent results, which I briefly summarize. So the findings were not consistent. So you may ask yourself why meta-analyses may reach different conclusions, even if they were published more or less at the same time. And on this slide, I summarize the reasons why the meta-analysis may reach different conclusions. First, study design. One should consider whether randomized controlled trials only were included. If non-randomized controlled trials were also included, were they evaluated separately? One should check participants to check whether studies were carried out in both a high-risk population and in the general population. Because if both populations were included, they should be evaluated separately. Intervention, and this is probably the most important take-home message. Consider that not all hydrolyzed formulas are equal. And finally, for outcomes, consider whether they assess the same outcome and check how the diagnosis of an allergic disease was made. Because differences of any of those may lead to different conclusions. And also, if you look at those 3 meta-analyses, systematic reviews and meta-analysis, which I just showed you, you can see that there were differences in the study selection. So this is our systematic review and the Cochrane review. And only some of those studies, because our aim was slightly different. And also, if you look at the Cochrane review and the BMJ review, again, you will see that many studies were included in both, not all of them. So this may explain why the authors reach different conclusions. But then an important question is, and this is something that probably you may wish to answer first yourself, would you recommend hydrolyzed formula to prevent allergy? So please answer yourself, and I will show you what are the recommendations. And as you can see here on this slide, the recommendations are not consistent. There are some recommendations, some guidelines recommended, for example, partially hydrolyzed formulas, formulas with documented safety and efficacy that they may be considered for all infants. But other societies, including British Society for Allergy and Clinical Immunology, they recommend against the use of a hypoallergenic formula. American Academy of Paediatrics in 2019 concluding there is lack of evidence that partially hydrolyzed formula or extensively hydrolyzed formula prevent atopic disease. And finally, let me focus on most recent document, EACI document, which once again, allow me to remind you, refers to IgE-mediated food allergy. And the statement here is there is no recommendation for or against using partially or extensively hydrolyzed formula to prevent food allergy in infants and young children. What are the practical implications of this document? Breastfeeding in all infants is preferable, but when a breast milk substitute is needed, professionals could help families consider the best possible alternative for the family individual circumstances, and the options discussed could include a hydrolyzed infant formula, because, allow me to repeat, there is no recommendation for or against, and this is because of the problems that we have with the evidence. Similar conclusions, by the way, was reached by the expert groups, and this was an expert group led by Professor Ivan van den Plas from Belgium. And here the conclusion is, at present, there is insufficient evidence for or against the routine recommendation of partially hydrolyzed formula for allergy prevention when compared to intact protein feed. And there is some evidence that meta-analysis focusing on trials with a similar design And one selected hydrolysate may conclude that there is some effect on allergy prevention, mainly atopic dermatitis. So the decision is yours. However, please remember that there are some newer studies or newer results, and I would like to discuss them in more detail. After all these guidelines were published, the 20-year follow-up of the Gini study was also published. And this is a study which is probably well known to you because it was discussed for the last 20 years, if not more, at various meetings. So only very briefly will allow me to remind you that it was a double-blind randomized controlled trials. At least at the very beginning, it was double-blind in high-risk population. And the interventions, there were 3 types of hydrolyzed formula: partially hydrolyzed wheat formula, extensively hydrolyzed wheat formula, and extensively hydrolyzed casein formula. And the comparison was a randomly assigned group was with a regular cow's milk formula fed group and non-randomized reference groups. And these investigators looked at the number of outcomes such as atopic dermatitis, allergic urticaria, food allergy with manifestation in the GI tract, allergic rhinitis, and asthma. What is important in this study, that the diagnosis was confirmed by a second physician, a trained allergologist, again, especially at the very early, during the first 3 years of life, so when it was still blinded. And for funding, it was governmental grant. And this is the study which showed that at least until 6 years of age, their allergy preventing effect was documented for 2 types of formula. And these were extensively hydrolyzed casein formulas and partially hydrolyzed wheat formula. And this allergy preventive effect has been seen and persisted until 6 years, as you can see on this slide, but also later on, it was when the findings were reported at 15 years. There was reduction for eczema, also for allergic rhinitis, for the same type of formula, and for extensively hydrolyzed casein formula, there was a reduced prevalence of asthma from 18 to 15 years of age. And what is new, and that's why I'm presenting it here, and a 20-year follow-up, this is very impressive. Any one of you who was involved in any kind of clinical trials understands how difficult it is to keep participants in the study and to keep them for 20 years. It's very impressive. So congratulations to the study team. And here you can see again these beneficial effects for 2 types of formulas, partially hydrolyzed wheat formula and extensively hydrolyzed casein formula. For asthma, for prevalence 16 to 20 years, and for eczema, for cumulative incidence from birth to 20 years. So the conclusion for these 2 types of formula was that there was reduction in the prevalence of asthma after puberty, and those 2 formulas retained their effect on eczema until adulthood. For extensively hydrolyzed wheat formula, the authors did not support the idea of this formula was not efficient when it comes to preventive effect. So the findings confirm the concept that early nutritional intervention with certain hydrolyzed formula, if exclusive breastfeeding is not feasible, has a preventive effect until adulthood for both eczema and allergic airway manifestation. So let me finalize this part of my presentation of hydrolyzed formula, that the discussion, especially in the context of the Gini study, a 20-year follow-up, is likely to continue. Now let me move to another intervention, which is being discussed every now and then, which is avoiding cow's milk-based formula in early childhood. And please again reflect on the following statement. Avoiding cow's milk-based formula may not reduce cow's milk for allergy in early childhood when the formula is consumed on a recurring basis. And again, you may strongly agree, you may be undecided, or you disagree. So please reflect on these statements, and I will discuss it in more detail. Okay, this comes again from the systematic review, which was performed by IACI, and you can see that for avoiding standard cow's milk formula, there was a range in the outcomes from 22% decrease to 2% increase. This was based on 7 randomized control trials. And when it comes to avoiding supplement of cow's milk in first week of life, this was based on the results from 1 randomized control trial. There was a 6% decrease. When it comes to the recommendations, which were formulated based on this evidence, so here are the recommendations. In the first week of life, the IACI task force suggests avoiding supplementing with cow's milk formula in breastfed infants in the first week of life to prevent cow's milk allergy in infants and young children. And after the first weeks of life, for infants who need a breast milk substitute, there is again no recommendation for or against the use of regular cow's milk-based infant formula after the first week to prevent food allergy. And here the discussion again may continue. And this is because especially what to do during the very early, the first week or first months of life. Because there are still 2 studies, one by Urashima, which was included and was considered when formulating the guidelines. And this study shows that early cow's milk formula is tied to subsequent allergies in infants. And this study is not included in the, or it's not part of the evidence base because it was published only later on. And Japanese study by Sakihara, which shows a daily ingestion of at least 10 milliliters of cow's milk formula between 1 and 2 months of age prevents the development of cow's milk allergy. So the data are, they are not so easy, by the way, to interpret, but anyway, they are controversial and contradicting, I would say. So the discussion about avoiding cow's milk-based formula is likely to continue. And this brings me to the next intervention, which is of interest, and this is timing of introduction of complementary foods and potentially allergenic foods. Again, please reflect on the following statement. Allergenic foods may be introduced when complementary feeding is commenced anytime after 4 months. And again, please consider whether you strongly agree, you are undecided, or you disagree. So please reflect on it, and I will comment on what is the current evidence and what are the recommendations. So until 2007, 4 allergy societies advocated allergen avoidance for prevention of food allergy. But this has changed, and this was mainly because of the findings from a number of randomized controlled trials, including 2 studies, which are probably the most important for this discussion. And one is the LEAP study, randomized trial on peanut consumption in infants at risk for peanut allergy, and the EAT study, randomized trial of introduction of allergenic foods in breastfed infants. Both were published in New England Journal of Medicine. Special interest should be on the LEAP study, which some people call as a landmark study because it resulted in definitive changes in infant nutrition. And it's not surprising because if you look at the effect in the avoidance group compared to the consumption group, and the consumption means that the peanuts were introduced early in life, starting 4 to 11 months of age, and they were consumed until 5 years of age. And you can see here, absolute risk reduction was almost 12%, and relative risk reduction was 87%, with number needed to treat 4. So it's really a landmark study which really shows that this early introduction is effective. Of course, there is no ideal study, so one of the questions people are asking is how relevant is early peanut introduction in countries with low peanut allergy prevalence? Well, the best would be to repeat the EAT study in countries with a low prevalence. Of course, it's not so easy, so we have to find the solutions. And if you look at the recommendations on potential introduction of potentially allergenic foods from different organizations, you will see that they are very consistent, that allergenic foods should be introduced around 6 months, but not before 4 months. Of course, there might be some differences between different recommendations, but generally, this is a direction into which they go. And again, I would like to focus on the most recent recommendation from IACI. And again, it only focuses on IgE-mediated food allergy. So the IACI task force suggests against restricting consumption of potential food allergens during pregnancy or breastfeeding in order to prevent food allergy in infants and young children. And there are also some specific recommendations for hen introduction. So the IACI task force suggests introducing well-cooked hen's egg, but not pasteurized or raw egg, into the infant diets as part of complementary feeding to prevent egg allergy in infants. And according to the studies, it appears that the best age to introduce egg, also peanut, which I will discuss in a moment, is from 4 to 6 months of life. And what is really important, it has to be well-cooked hens, well-cooked egg. For peanuts, in population with a high prevalence of peanut allergy, the IACI task force suggests introducing peanuts in an age-appropriate form as part of complementary feeding in order to prevent peanut allergy in infants and young children. And again, allow me to repeat, according to the studies, it appears that the best age to introduce peanuts is from 4 to 6 months. And what is recommended is 1 heaped teaspoons of diluted peanut butter, for example, each week. So these are practicalities of how these peanuts may be recommended. So my summary number 4 for this part of my presentation, which is timing of introduction of complementary food, that sooner rather than later. And if you look at the dictionary, what does it mean? Sooner without too much delay. So this is what is currently recommended. Okay, so I discussed exclusive breastfeeding. I discussed the use of dietary products with reduced allergenicity. I discussed timely introduction of complementary food, and I showed you what is the evidence, what are the recommendations. There are other early nutritional strategies for preventing food allergies. And again, I would like you to reflect on the following statement. There is sufficient evidence to recommend routine supplementation with probiotics during pregnancy, lactation, and early life to prevent the development of allergy in children. And again, please consider whether you strongly agree, you are undecided, or you disagree. In your opinion, there is sufficient evidence to recommend routine supplementation with probiotics. And as before, let me now comment on the evidence. So if you look at the evidence, there is no recommendation for or against prebiotics, probiotics, or symbiotics, also for vitamin and fish supplements. And this applies to pregnant and or breastfeeding women and or infants. And of course, we are here in the recommendation, all probiotics, all prebiotics, all symbiotics are discussed all together, but each one of them has to be evaluated separately. But even when we look at individual data, there are no data, there is no sufficient evidence to recommend any one of those, any specific prebiotic, probiotic, or symbiotic. So no recommendation for or against. So my summary number 5 for this part of my presentation is for other intervention. I guess it's true that what they say, if you wait long enough, everything changes. So it's very likely, because there are many studies ongoing, that in the future it may change. So the question is, where are we now when it comes to allergy prevention? We believe this resolves all remaining questions on this topic, and no further research is needed. Well, this is what all of us would like to see in any of the papers. It doesn't happen very often, and we are not there yet when it comes to allergy, to studies on allergy prevention. And this comes from the ERT recommendation. Further research is still needed. There remains uncertainty in how to prevent food allergy, and further well-powered multinational research using robust diagnostic criteria is needed. And I showed you, and I discussed some of that, for example, peanut introduction in countries when there is a low prevalence of peanut allergy. To repeat the LEAP study in another population would be really desired, and many other questions which needs to be answered, hydrolyzed formula, for example. Okay, so allergy prevention, what to advise in 2021. Exclusive breastfeeding for 6 months is a desired goal, even if, and they showed you, there is no convincing evidence that it reduces the risk of allergies. For protein hydrolysates, there are differences in the recommendations. EACI, in regard to IgE-mediated food allergy, the recommendation is no recommendation for or against. And please know that each formula should be evaluated separately. And I also showed you the results, very new results, a 20-year follow-up of the Gini study, which may contribute to the discussion. Allergenic foods, including peanuts and eggs, around 6 months, but not before 4 months. And all the recommendations are quite consistent. And for food supplements, prebiotics, symbiotics, fish oil, vitamins, there is no recommendation for or against. But even if the best evidence is available, even if the best guidelines are available, it does not automatically lead to improved health outcomes. And this is a slide which I showed every now and then. What are the barriers between evidence and clinical outcome? And there is a role for physician and for patients, or in our situation, for parents of patients. Physicians should be aware of evidence. They have to accept the evidence. The evidence should be applied. Physicians should be able and act on the evidence. But there is also the role for patients. They have to agree on the evidence of the parents of our patients. They have to agree, and they have to adhere to the recommendation. So once again, many barriers which extend from awareness to adherence.